joining us this afternoon for our 2020 Roanoke Pregnancy and Postpartum Resource Summit. We're joined today by Dr. Jennifer Wells with Carillion, and she will be talking about maternal mental health, mental illness in pregnancy and beyond. As I mentioned, we will be taking questions using the Q&A feature below, but definitely welcome any comments in our chat box as well. Without further ado, please join me in welcoming Dr. Jennifer Wells.
Hi, everyone. I hope, Emily, you'll stay there, right? Because I can't see the chat box anymore. So if there's something that comes up, will you see it?
Yes, absolutely.
Okay, good. So good morning, or I guess it's afternoon already. Let me just have a little caveat. If you hear snoring noises, that is my adorable French bulldog who's asleep at my feet. So don't mind that. She sometimes sounds like a motor engine. And today I'm here to talk about maternal mental health. So basically, mental health issues in pregnancy and a little bit beyond. I'm an OBGYN trained psychiatrist, and I'm also boarded in addiction here at Carillion Clinic. And I specialize in taking care of women who have mental health issues in pregnancy and around the perinatal period. So my slides were originally developed for doctors and nurse practitioners and the like. And so if you see anything that doesn't make sense, please shout it out. I tried to condense it down so we could get through just some of the simple stuff. And I kind of have some basic takeaways that I'll review in the end that I hope will stick with you. So you'll know where to reach out for resources if you need it, and you'll know that you're not alone. So without further ado, we're kind of going to talk about the origins of maternal mental health, mostly because they're funny. Understand some of the reasons why we care so much about perinatal health, because it does affect women, children, and families. We're going to look at the most common forms of depression and anxiety associated with the perinatal period, including postpartum blues, depression, and psychosis. And then talk about some basic treatment options, and just more so that there are treatment options, and the idea that you're alone and just have to suffer through it should no longer exist. And I want to dispel that myth. So where do we begin? I often like to start any talks I give with a little bit of history. And we know that mental health disorders in women dates all the way back to 1900 BC. In Greek mythology, women's madness was thought to revolve around the idea that your uterus was sort of poisoned and evil and filled with venomous humors, and it was sad, it was melancholic, and it used to roam around your body in search of happiness. I can't make this stuff up. Even Plato, Aristotle, Hippocrates all opined that the uterus was sad and wet and prone to putrefaction, and part of what it desired was to procreate with the male penis because it was thought to be clean and full of life and give rise to new birth, and that was what would ail the illness of hysteria that perplexed women. And as we look through history, we sort of learn maybe that men who were predominantly responsible for medical thought of the time kind of used this catchphrase hysteria as a way to sort of understand maybe the emotionality of women. And so, like I said, they used to think that women, in order to control their hysterical paroxysms or panic attacks, as maybe we look at it now, but their sort of hyper emotionality, they needed to have sex with men because that was going to be healing and cleansing. And this continues all the way through into the 1st and 2nd century AD. Around that time, Cyrannus, who's the modern father of OBGYN, sort of hypothesized, no, you don't need to have sex with men. What you need is a break. You need to get away from men, and women's disorders arise from the toils of procreation, and perpetual virginity is a woman's ideal condition, right? So there's somebody looking out for us. In any case, this sort of was perpetuated through medical science, including and up to Freud, who postulated that women experience hysteria because they were unable to reconcile the loss of their metaphoric penis. So we're so sad and emotional because we, in fact, don't have a penis at all, if you can believe that. And I think it's interesting, this idea of smelling salts that women carried around in their pockets into the 1900s was based on this idea that if you put the smelling salts near your nose, your roaming uterus that had escaped from its position in your pelvis and was squashing your lungs and causing suffocation, if you sniff the smelling salts, it would be so upset by the potency of the smelling salts that it would go descend back down into your pelvis where it belonged. So, and eventually, there was created this idea that if women had orgasms, then their hysterical symptoms would decrease. And that also plays into how sex played a role and what we believed was the problem with women's emotionality. And it wasn't until hysterical neurosis was taken out of the DSM in 1980, and from about the end of World War II, we started looking at hysteria, this diagnosis, as more properly classified as anxiety, depression, conversion, and the like. But from pretty humble beginnings, has this idea of perinatal medicine evolved. So what are we talking about? The cluster of diseases that I most commonly deal with around perinatal mood and anxiety disorders, or PMADS, is prenatal and postpartum depression and anxiety, postpartum panic disorder, perinatal obsessive compulsive disorder, postpartum PTSD, postpartum bipolar disorder, and postpartum psychosis. And you can see too on the slide, I have depression in puberty, this premenstrual dysphoric disorder before the perinatal period, and postmenopausal syndrome after our reproductive years are over. So we watch as hormonal changes affect mood throughout the women's life cycle. So in the perinatal period, we're talking about perinatal mental illness are psychiatric disorders that are prevalent during pregnancy and as long as 1 year after delivery. If the disorder is present before pregnancy, recurring along with disorders that emerge during pregnancy or in the postpartum period, we consider that all perinatal mental illness. So if it's happening while you're pregnant, it's a perinatal mental illness. Short and sweet. And why do we care about these illnesses? Well, mood disorders, we've known, as we started our lecture with history, do correlate with hormonal changes. This has been recognized likely before present day, sometime around the 1600s. Depression, we know, is costly. It's the leading cause of disease-related disability among women, and women are 1.6 to 1.7 times more likely to suffer from depression or perinatal mental illness during their lifetime than are men. Although I will say, we don't say it enough, but men are also subject to perinatal mood and anxiety disorders. We know that suicide is the fourth leading cause of death in reproductive aged women in the US and worldwide. And in the US, depression is the leading cause of non-obstetric hospitalizations for women. So we watch that perinatal mental health disorders, or PMADs, affect maternal health. We're going to see that they affect pregnancy health, and then they affect our infants and children's health as we go forward. You'll hear this a lot, that perinatal depression affects about 1 in 7 women. So in the US in 2016, there were 3.95 million births of women aged 15 to 44. Of those women, about 15% and perhaps as high as 20% suffered a perinatal mood or anxiety disorder. So that's nearly 600,000 women. We know that the risk of suicide is 70 times higher in women with psychiatric disorders during the first year after childbirth compared to the general female population. And suicide is the third most frequent cause of death among both early and late postpartum women, behind natural causes and injuries. So we saw before it was fourth back here, fourth leading cause of death in reproductive age women in the US and worldwide. Third among early and late postpartum women. So this can be a very pivotal time for women who are suffering from mental illness. And we know it was estimated, I just saw a study about this, that the cost of perinatal mood and anxiety disorders in pregnancy in the US is somewhere between 14 and 15 billion dollars a year, with a B, billion dollars. So very costly for our nation to handle. Here's a schematic. If you learn better from it, sorry, my bad. It's postpartum depression is the most common complication of childbirth. And one of the things I like to point out is at the bottom of the screen, only 15% of women with postpartum depression ever receive professional treatment. And I think one of the biggest takeaways from my lecture, or even from today's symposium, is that mental health illness in pregnancy is not something to be ashamed of. It's relatively common, 1 in 7, and is very treatable. And there are people in our community who are willing and able and educated on this subject who can treat you, myself included. From a pregnancy standard, we know that there are complications in pregnancy associated with depression, including obstetric risks like miscarriage, preterm labor, abruption, preeclampsia. There can be inadequate weight gain, underutilization of prenatal care, so women aren't getting the care that they should for their babies. We watch an increase of substance use, an increase in premature birth. We see recurrent episodes of depression, and as I said before, suicide. Also, and this is sort of separate, but if anybody's watching, or the women out there who have friends who suffer from bipolar disorder, that is the pregnancy period is a particularly difficult time, or can be, for those women. They are subject to experiencing more mental health issues during pregnancy and within 1 month of delivery. Their incidence of having more serious complications increases, including postpartum psychosis. And then for those who are suffering from anxiety, we know that people who have prenatal anxiety are often at the highest risk for postpartum depression. And then I also want to introduce this idea of fetal programming. So like I said, we know that PMEDS interferes with maternal health, pregnancy health, but there's also an impact on your fetus's health and therein the child's health. So we look at perinatal mood and anxiety disorders as an intergenerational disease, meaning depression or anxiety in a mom can actually affect the mental health and physical health of the baby. So fetal programming is this idea that the in utero environment can modify the expression of genes and interact with the tissues and organ systems of a developing fetus, such that it can result in long-range consequences for the function of those tissues, meaning that anxiety and depression in a pregnancy can actually contribute to more long-term health consequences in the baby. We know that PMADs in early development, in a pregnant woman, can affect developmental outcomes, including neurosynaptic development, regulatory development, and the meeting of developmental milestones in children. And here's a schematic that if a mom is stressed, the baby is stressed, that affects the development of the baby's organs, that then can lead to an increased risk of cardiovascular disease, hypertension, coronary artery disease, obesity, diabetes, as well as and including neurologic and psychiatric diseases. So it's pretty important that anxiety or depressive disorder is treated. And in terms of infant and child health, as I said, we know that PMADS, or perceived life event stress during pregnancy, is associated with adverse outcomes in the infant, including IUGR, preterm delivery, decreased APGAR scores, low birth weight or small for gestational age, smaller head circumference, and an early termination of breastfeeding. So why do we care from that child perspective? Well, an early termination of breastfeeding or a smaller infant can be a less healthful infant. And also, we can have, as I said, poor infant neurosynaptic development and changes in brain morphology that can then affect social and emotional processing for years to come. We know that undiagnosed postpartum illness can dysregulate infant sleep and feeding. And that's often because if you have a depressed mom or an anxious mom, she might misread the cues of her infant. So let's take a mom who's depressed, has a baby, the baby wakes up from a nap and is crying. And the depressed mom might read the cue of the crying baby as, oh, I know, I'm sad too. The world is such a horrible place. I understand how sad you are, right? She will assume her baby is depressed like she is instead of just hungry or has a white diaper. And we know that responsive caregiving during feeding routines in infancy is associated with positive dietary habit formation in later childhood. So it's really important that the mother and the baby work together. And we know that if that dyadic component, we'll talk about that in a minute, doesn't happen, then there can be what's called affective dysregulation, that the mother is sad and the baby is in turn affected by her inability to monitor the cues appropriately. So we talk about moms and babies as this infant caregiver dyad. Like the baby only exists healthfully with a healthy mother, right? The infant exists and develops within the context of this healthy, loving relationship with their primary caregivers, mom or dad or both. In a well-functioning dyad, a secure attachment develops and the infant's needs are consistently and sensitively met by the primary caregivers, right? But just like we said, if the mother is depressed and anxious, and same with a father, that might disrupt the secure attachment of the infant. And when that happens, that attachment relationship gets jeopardized. The infant then can have disturbances in behavior and development, disturbances in attachment and bonding, and deficits in later developmental stages. So it's so critical that we have healthy moms going into pregnancy, through the pregnancy, and in the postpartum period, as well as dads. So here's just a sample schematic, right? If a mom is experiencing adversity, then her ability to make a secure and healthful attachment to her baby may be disrupted, and then the baby is then impacted, and so is the mother. Her illness will often worsen as she knows she's unable to care adequately or feels she is caring inadequately for her infant. And then we know as children grow in the setting of a mother who has depression or anxiety, or a father if he's the primary caregiver, that can impact all domains of child development: cognitive, behavioral, language, motor. Interesting, maternal and paternal depression at about 4 months postpartum has been linked to both internal and externalizing problems by preschool age. So that's kids externalizing problems, acting outward, internalizing shame and poor self-image as early as 4 months postpartum, right? So it's critical that we address these issues. And we know that children of highly anxious mothers have twice the risk of ADHD and anxiety. I will say the majority of these studies are quite small, so whether that's definitive, I think remains to be seen, but that's some of the data that we do have. We know as the infant grows into a toddler, grows into a child, grows into adolescence, the effect of fetal exposure to PMAD still continues, causing an increased risk of psychiatric illness in the adolescent and the young adult. So that transgenerational illness theme comes back. Increased risk of substance use disorders, diminished vocational capacity. So these children don't grow to their full potential in terms of their employment. They're at increased risk of medical illness, including hypertension, diabetes, cardiovascular disease, like we spoke of earlier, that fetal programming bit. And as you can see, the associations of maternal depression are really complicated. But right down here in the lower left corner, you can see that so many psychosocial issues can impact how the fetus develops, can then impact the child that grows, can then impact the adolescent and adult that child becomes. So who's at risk for perinatal mood and anxiety disorders? Minors, people with a past history of mental health issues, persons who experience childhood adverse events, persons who have had a perinatal mood or anxiety in a prior pregnancy or postpartum, persons with a history of sensitivity, women, sensitivity to hormonal shifts, unmarried or poor marital satisfaction, thyroid dysfunction, poor social, familial, or financial well-being, crisis related to the health of the baby or the mother, can be during pregnancy, during or after birth, or a high needs infant, unplanned pregnancy, a recent or unresolved loss of pregnancy, a recent move. We often find in persons who have a type A personality that are trying to be the perfect mom and feel like they can't do it, that can spike mental health issues in the caregiver. Complications in pregnancy, making it harder to bond and attach to your infant. And I see this so often in my work, that women who give birth and then have poor sleep or unable to cobble together a block of sleep each night, they're at increased risk for suffering from postpartum depression or anxiety. Parents who have a lack of foundational attachment as a child. So if they did not have a healthy, loving relationship with their parents, they're actually at risk for having that same issue with their children. And unresolved feelings about a miscarriage, abortion, or adoption. And so as you can see, a lot of the risk factors and exacerbating factors can take place for the parents in their own childhoods. And that brings up this idea of adverse childhood events. So there's a big study out of California done by Kaiser that told us that traumatic events in childhood can have lasting negative effects on the health and well-being of the adult that grows into that is then transmitted once again through epigenetics or fetal programming into the child that then grows. So there's that transgenerational piece. And I only wish to say, for those of you who are listening or see this, that maybe reflecting on your own childhood and the things that you were witness to may give you a greater sensitivity to the parent that you can become, and also to maybe reflect back on, have you dealt with the things in your own childhood such that you don't transmit the stress and trauma that maybe you suffered from into the next generation. It's a tough thing to talk about, and it's hard to manage trauma, but there are treatments and there's great therapy. And I just encourage you to think about it while you're building your own families. And another final schematic about it, that childhood maltreatment can beget gestational changes, can beget fetal changes that beget a child having medical and or psychiatric issues. So it's complex, but worth considering. And part of where we're going to get to is that it is harmful in and of itself if you have depression and anxiety during your pregnancy and you don't get that treated. I feel like it comes up quite often in my work that people are afraid to take medications, or medications aren't always the answer, but are afraid to reach out for treatment help. And what I sort of want to emphasize is that by doing nothing, by being afraid to reach out, or by choosing not to reach out, you're not keeping your infant safe. You are, in fact, choosing a path that might be dangerous in the future. It's not 100%, but definitely we have a number of treatments that can help women, families, husbands who are dealing with prenatal mood and anxiety disorders to help them cope with it such that they can have a healthier pregnancy and a healthier child and family going forward. So earlier we talked about the perinatal mood and anxiety disorders. I'm sure if anybody's seen TV, they know there's a number of stars who have suffered from postpartum depression is the one that comes up most often, but a number of stars have also come out having said they have bipolar disorder. And as I said before, those women are at particular risk in the postpartum period. So if you have a friend or you know someone who has bipolar disorder who is pregnant, you might want to encourage them to ensure that they're adequately treated or in the hands of a good healthcare professional who could help them. But the most common is prenatal or postpartum depression. And depression in pregnancy looks much like depression outside of pregnancy. And the symptoms include a depressed mood, anhedonia, or an inability to feel happy, sleep and appetite disturbances, impaired concentration, feeling tired, worthless, guilt, hopelessness, all the way to suicidal ideation, which means you are thinking it would be better not to be on this earth. That's sort of a passive suicidal ideation, all the way up until I want to die, to someone actively creating a plan to do so. We also see that psychomotor agitation or fidgetiness, worrisome, moving around a lot, and lethargy, kind of the opposite of that, tiredness, inability to engage, are more prominent in postpartum depression than in MDD or major depressive disorder. Postpartum depression is also associated with mood lability or mood swings, a preoccupation with infant well-being, anxiety with ruminative thoughts, and panic attacks. And I think this sort of explains a little bit why the dyadic development can be interrupted, meaning you're so preoccupied with your infant's well-being and you're anxious and have trouble stopping intrusive thoughts about how your baby's doing, that then impairs your ability to simply love and respond to your infant. And that's that healthy mother-child dyad bond we were talking about earlier. Lots of people ask about the difference between postpartum blues, postpartum depression, and postpartum psychosis. So from the standpoint of frequency, we know lots of people experience postpartum blues. 50 to 75% of new parents, including dads, happens about the first 2 weeks postpartum. You can be irritable. You can have fluctuating mood, like you cry at a commercial. Emotional reactivity, you're kind of up, you're down, but it's sort of mild. You manage it, goes away all by itself, and you don't think anything of it really, except that you're like, why am I crying at this commercial? In postpartum depression, that's upwards of 15 to 20% of new parents in the first year postpartum. Those symptoms we just talked about before, guilt, anxiety, depressed mood, problems with sleep, and suicidal ideation. And that has a moderate to severe or prolonged course, right? It can continue upwards of months to a year, especially without treatment. And then at the far end of the spectrum is this idea of postpartum psychosis. It's very rare, happens about 1 in 1,000 women. It results in mixed or rapid mood cycles with agitation, and often is associated with psychotic symptoms, which for me means delusional thoughts or hallucinations, seeing things or hearing things that aren't there, often around the baby. Hearing the baby cry when the baby isn't crying, hearing the baby cooing or making noises when the baby isn't in the house. And it often results in disorganized behavior. And we consider this a severe psychiatric emergency. That person needs to be evaluated in an ED or by a psychiatrist really quickly. It doesn't happen very often. And as I said earlier, it's most often associated with women who have a history of bipolar disorder, but not always. So most common is postpartum depression. And here's just a schematic that helps you remember what are the symptoms. When we talk about postpartum disorder, like I just wanted to quick mention, there's a strong and consistent evidence base that bipolar disorder and postpartum psychosis are associated, and women with bipolar disorder have a 1 in 5 risk of a severe recurrence after delivery. So those are the women that I really would like to see have a birth plan and be seen by a psychiatrist who specializes in perinatal mental health as they're deciding to get pregnant, while they are pregnant, and in the postpartum period. So I brought up a little schematic of just what the subsets look like. So you can see blues encompasses the great majority, postpartum depression right behind, then anxiety disorder, and that little circle right here is postpartum psychosis. Mostly encompass in bipolar disorder, but some part of postpartum depression and postpartum anxiety disorders as well. I included a slide about postpartum psychosis just in case people want the information on it, but you likely will not see it. And if you are seeing someone that you're worried about, then I want you to call 911 or get them to an ED for treatment and assessment. Other way around, assessment and treatment. So what are some treatment options? I will tell you that there are many. As a specialist in these disorders, I use every tool in my toolbook, and that includes, but is not limited to, medication. But I do want to point out that the stigma against using medication in pregnancy is dangerous. Coming off medications to have a, quote, natural pregnancy can pose potentially life-threatening risk to both a woman and her pregnancy. And I hope I made this clear in terms of the idea that coming off medications or not being treated for your perinatal mood or anxiety disorder means that you're having a more natural and therefore better pregnancy. That's simply not the case. We have a wealth of information and data that tells us that women who are not treated for their perinatal mood and anxiety disorders are at great risk for worsening of their own psychiatric illness, but also for medical and psychiatric complications in their child and as their child grows into their adulthood. So I hope I've sort of impressed that point, that it's not that you necessarily need medication, but the idea that I think a lot of people carry it around that medication is dangerous in pregnancy is simply not true. We have a lot of information now collected on women who have needed to take medication in pregnancy that tells us that the great majority of medications are safe to use in pregnancy and have minor side effects. And most OBGYNs can talk about what those side effects are and give you a picture of it. And if they're not equipped to do it, then they can refer you to someone like myself who can give you that information. If you have suffered from depression or anxiety in the past, or are worried that you see these symptoms developing in yourself during your pregnancy or in the postpartum period, I want you to see a qualified psychiatrist. You might start with your OB. Your OB can refer you to someone who can help. If it's an emergency, you go to the ER or the emergency department. I tell women who have been taking psychiatric medications, when they find out they're pregnant, don't stop your medication. Call your OB. Make the appointment first. Continue your medication. All but only a very few do we stop. And if you're on most medications, you're going to continue them in some fashion. But just consult a doctor before you choose to stop them. If your doctor does make a decision with you that it's necessary to stop a medication, often a taper is better for your psychiatric wellness than just stopping the medication altogether. As I said before, exposure to psychiatric illness counts as an exposure to the child, right? They often say that if you're taking a medication, the baby has been exposed. Well, if you have depression or anxiety, the baby has been exposed to that as well, and that has ramifications, as we've seen. Nearly all moms can benefit from therapy or peer support, and that includes church, your exercise group, Huddle Up Moms, whatever it is in the community that you find helpful, I want you to engage because it will help your mental illness. I talk a lot about exercise, meditation, mindfulness. No one treatment program that I use works for everybody. We change it up, we do different things, we find out what works for you, and we use it to build you the healthiest person you can be, to have the healthiest pregnancy, to have the healthiest child. Certainly, healthy eating and regular sleep help as well. If you have serious mental health issues like bipolar disorder or have been treated kind of on a medication regimen that includes several medications, I encourage you to talk with your psychiatrist about pregnancy planning and or your OBGYN to kind of come up with a relapse prevention plan for your pregnancy and the postpartum period. This just talks a little bit about what that looks like. And I've included in the slide some patient and provider resources that you can look up for more information. They're helpful. They talk about medications, but they also talk about the same things that I've just talked about and can give you some support. I also included this slide from Postpartum Support International because it's a good all-encompassing slide, and down at the bottom is their number and the text line, so you can try them. And then within the community here in Roanoke, I've cobbled together a number of resources that can help build community supports for moms who are struggling or would like just extra support. And that's it. That's all I have. So thanks so much. I can answer questions if we have any, or wrap it up.
Thank you so much. We have just a couple questions. I guess in your opinion, why do you think so many women suffer in silence?
I think one, our society is sort of built around this idea that you should be able to do it all, right? That's what every magazine, that's what every TV station, every TV show has built. Moms who are managing everything from, iconic Carol Brady all the way through to modern day images. And I just don't think we as a society have had a lot of acceptance of mental illness at all. And then when you cobble together pregnancy, there's this other association that pregnancy is this wondrous, joyous time for everybody, and a woman just blossoms and grows into this wonderful human being, and everything about it is perfect. And that's just simply not the case. It's an incredibly stressful time with changing relationships, finances, often home life, employment. Your body is changing. And so it's not surprising at all that women struggle in adjusting to all these changes. And our society just hasn't been as quick to adjust to that, to understand that the perfect woman doesn't exist, that it's unrealistic, and it's actually kind of boring because our, tarnishes, our dents and dings are what make us special as humans.
Great, thank you. And it's definitely a challenge trying to be a mom and trying to do it all. You mentioned in your presentation how PMADS affects early developmental outcomes, especially during the fetal programming. Do you think you can share with our audience just some signs of that developmental outcomes and just things that moms should look out for and how we can, work with that?
I think the greatest, that's a tough one. I think first and foremost, it's important that moms are looking in the mirror first, are addressing their own mental health issues, right? The ball starts and stops with us first. So you have to look at yourself and say, are there things that I have unresolved, or have I been masking a depression or an anxiety disorder that I need to get treated? If you go into your pregnancy the healthiest you can be, you're going to have the healthiest dyadic bond, the healthiest bonding with your baby. But that includes, your physical health, because we know that obesity and hypertension are also stresses on the baby. So you are looking at yourself first. So let's say you do that, you feel like you've got everything as well oiled as you can, and then in the postpartum period, I think what you're looking for is a baby that's developing along the milestones with the pediatrician, that behaviorally is meeting milestones, so not just physical ones, but emotional ones, and that any problems that are seeming to creep up that you're discussing with your pediatrician and you're referring out to make sure that you sort of nip them in the bud before they become anything. And that's some of the resources that I put up include community resources like Healthy Families and the Child Health Investment Partnership of Roanoke, or CHIPS. So Healthy Families and CHIPS are two programs that really work to educate moms about infant growth and also how to interact with your baby once it's born to facilitate development and meeting emotional behavioral milestones as they grow.
Great. Thank you so much.
Sure.
I don't see any other questions in my email or in the chat box, but I wanted to thank you again for your time presenting with us, and appreciate the audience for joining us in this discussion. We'd also like to take a moment to thank our summit sponsors, Dr. John Harding and Star Lactation, for their support in our resource summit and supporting mothers in the Roanoke Valley. As I mentioned at the beginning of the session, we will be sharing all of these recorded workshops on our website and for everyone that has registered. And your contact information is also shared in our summit brochure as well. So, if anybody has questions, please feel free to reach out to Dr. Wells. And again, all our sessions are recorded, will be available, and we thank you again for joining us this afternoon.
Thank you.
Have a great day.
You too.